we do sort of like have this armor that's self-protective that is necessary. But it becomes pretty extreme for a lot of folks. So the Megan case, the is an ER doctor, and the stuff you see in the ER is pretty traumatic. And you get to the point where, like, you tell stories over dinner and other people are crying, and you're like, wait a second, like, was that traumatic? And the way I think about this too is like there was that football player who coded on the field, and everyone was like, oh my gosh, what is that? Like, that's the most traumatic thing I've ever seen. And all the healthcare workers on social media were like, is that traumatic? Like, that watching that is traumatic. We saw 10 of those yesterday, right? Like, we have no idea. Like, we basically are numb to a lot of the things that, like, of course would make other people feel. And so in doing that, you are really protecting yourself, but we shouldn't do it all the time. But we do it so much that, like, you don't realize that you haven't had emotions in 10 years, and then you come to my office and cry. Like, I would say the most common thing for someone who finally shows up to see me would be like sort of what happens to her, which is just like saying hi and crying and having no clue why, and also being very confused because you haven't cried in a really long time, and being very embarrassed because we apologize for big emotions, especially women, but all people really do for different reasons. Like, big emotions scare people. I don't want to put that on you, like, etc. And for me, I try to sort of say everybody does that in here, but I think that it makes sense that, like, finally having a space that is for you to share or is about you and no one else might make you almost like overwhelmed to the point that you have emotion just by simply like existing in a space that asked you about you.
When people want to seek mental health help, the stigma that goes along with it. Can you talk about how that is such an issue?
Yeah, I mean, and maybe it surprises people a little that people in healthcare stigmatize mental health, but maybe it doesn't, because you've been in a situation where you wanted to talk about mental health and you didn't feel like the person who was treating you was that comfortable with it, and some of that comes from that, and some of that comes from the fact that if you asked me about how to suture, I wouldn't be comfortable either. It is an actual skill set that I went to 4 extra years to learn about. So the fact that a surgeon is less comfortable with it should make sense, not just what made a surgeon go into surgery, but so much else there, right? And so, you know, eh, like, if you look at studies, like, med students that come in don't actually think that like mental health is something to hide. But if you ask them what everyone else thinks, they worry. So they worry like, will my colleagues judge me for it? Will my supervisors judge me for it? Will my residency applications be judged for it? Will patients judge me for it? And because of all of those layers of fear and what you see modeled and what you hear, people don't talk about it when they get help. So it becomes sort of like a self-perpetuating cycle of like, of course, some of us are getting help, but we're not talking about it because we were told not to talk about it. Because if we talk about it, people will judge us for it. Then we also see like examples where, like, to take time off work, you have to be like actively hemorrhaging or hospitalized or whatever, right? And if the bar for taking time off is like that, mental health doesn't even like hit the radar because you don't see it for the most part. We aren't like really able to like articulate what it's doing to our day-to-day life that well usually. And by the time we're pretty well off, like pretty bad at that point, but still not actively hemorrhaging, right? And so also, like, it doesn't really fit in the what counts degree. And so if it doesn't count, and there's all this fear of what everyone else thinks about it, like, hiding it makes a lot of sense. And there's added fears, which I'm sure, like, as lawyers, too, about licensure and whether the licenses are going to ask you questions that are really actually illegal. And you guys could make that argument better than me, but like, like, really legally, they're only allowed to ask about current impairment due to the Americans with Disabilities Act. But a lot of these states are still asking things that are sort of like, have you ever been in therapy, right? Like, that's an absurd question. And, if you know that that's in existence, you might hesitate to go talk to someone to go ask for help, because they're going to take your license for it. And like, it's very unclear what they do with those answers. For the most part, if you went to therapy, they're not going to do anything about your license, but no one's ever said that, right? Like, no one's ever said, we asked those questions for this reason, we use them in this way. Just because you ask for help does not mean that we're going to take your license. But the existence of those questions and an underlying lore of like, oh my goodness, I know someone who checked the box and then they were followed around for the rest of their career makes people really hesitant. And we've made a lot of strides, particularly over the pandemic, particularly thanks to an organization called the Dr. Lorna Breen Heroes Foundation, to change like not just state by state because we have to do it that way, but to also change credentialing in different hospital systems, because that's just another layer of the same kind of questions. Like there's a big push with a significant amount of impact and change around that, but even that has been sort of recent and no one knows if they don't talk about it. And so again, the lore is like, don't do it, don't do it, don't do it, they're going to take your license. And you gave up like 10 years of your life to go to school, all your money, your entire identity, you have no hobbies, all your friends have money. Like it's, it's a lot to then just like lose. I mean, it's the same with sort of like Luke's decision to step back at all. Like it's the same thing. It's like, what, like I have to do what to take care of myself? Like I can't do that. Like I already gave up like so much to be here. I don't really know who I am if that's not what I'm doing, but also could I lose it? Like that's really scary. And I think in the context of all that, we forget like you could lose it because you're ill, like because you made a mistake, because you stayed until it was too late. And like we're so scared that we don't ask when we should, and we end up waiting so long that for the most part, most of my patients say something like, I haven't hurt anyone yet when they're in my office. Like, that's a terrible thing to say. Like, as a patient, if you're listening to this, like, you probably are like, that is terrible. I want my doctor to get help 10 steps before that. Not when they're like, I'm almost at the point of cutting off someone's wrong leg, but I didn't do it yet. Like, that's a terrible barrier. And that's sort of like what they wait for because of stigma, because of fear of licensure, because of this sort of like unhealthy bar of what counts. And it just makes it like, so we really wait a long time until we finally do it, or we get forced to do it because we do make that mistake or we do have something happen. And that's also not when I want people to ask for help too.
When, I was reading your book and what I've heard from friends that are in the medical field, it's like a hazing. I'm like, why do you have to? Hazing was supposed to be done away with in colleges. It, it, why are you hazing these new people that are coming in? And we've talked to other physicians where, especially in the field of gynecology and urology, that's a lot of our guests, where there's going to be a shortage and women can't see gynecologists in their area and they're having to travel. And thank goodness there is telehealth for some things. You can't have a telehealth exam, pelvic exam, but it
That
is
would
like
be interesting.
that's okay. I think that's illegal. But I don't think I would have seen that. But anyway, it is like a hazing to me. And when I was reading your book too, how they rolled back some things, like there was a thing you talked about, the 24-hour on call. And I can't remember exactly why did they take that back? Like, didn't they roll it back?
Yeah, sometimes it's like the data that they have to prove their points. And then like people having strong opinions about one thing or another. So like sometimes the data says something like more people didn't die when we had longer hours. And so what they take from that is, oh, we can keep the long hours instead of like, well, what else is there besides mortality or time in a hospital that should be measuring some of that? Those studies are all like very skewed for lots of reasons that are true too, which is if you report that you work extra hours, your hospital system can get dinged for it. And then you're working at a hospital that gets unaccredited because they're violating duty hours. So those studies are not like people aren't encouraged to be telling the truth of what their actual work environments are. So, I think that's all really hard. But yeah, we roll stuff back all the time if it's going to help what you want or what you
Wow.
need, you know? And that's a really like, you know, working that long can lead to like basically you're working drunk because that's what not sleeping can do to folks. And that's really, really hard. I luckily wasn't in a program that had that, but I had night float, which was a replacement, you know, where people work for 2 weeks at a time at night. And then so you're sort of tagging someone out. But yeah, I mean, it is hazing in a lot of ways. It's also, you know, the word resident. So the hospital was built on residents existing. It's called resident because they'd sleep in the hospital. Like that's what they were literally residents. You know, and it was built on their backs as a, you know, a hospital system really can't survive. Like a big academic hospital can't survive without residents. Private hospitals, your little community hospital, if you don't have residents, they figured it out, but the big academic ones with the most like caseloads function entirely on a resident seeing most of the patients and someone supervising, right? Like that's how we've grown to be. And if they're not in the hospital, who's in the hospital? And so it's really, really hard in that way. But I've never really understood like hard work is one thing, hazing's another. And I've never really understood that. We call it mistreatment, and somehow we think that's different than hazing. It's hazing,
It's hazing. Yeah.
but you know we don't. You know, some specialties are worse than others. Maybe in the same reason that like some frats are worse than others, some sororities are worse than others. But um, you know, I've always respected hierarchy in like a knowledge sense, but I've never respected it in a power sense. Like I don't think it's very helpful to exist where I'm up here and you're down here and I know more so I'm better than you, but instead like well like you're supporting me so how can I support you in supporting me and the rest of the team because that's true, right? Like I do know more. Like that's the point. Like I went to more school, I'm done with the school, I've been training longer, I've seen more patients like sure I respect you for knowing more, but I don't respect you for knowing more to the extent that now you can treat me terribly or like embarrass me in front of people or trick me into doing stuff or whatever it is. Like a lot of that stuff is just terrible or throw things at me. I've seen that happen a
Yeah.
lot. Like that stuff should just not be a thing, right? And so I think it's gotten better as like some of our accrediting bodies have paid more attention to it, but it's subtle. Some of it's really subtle in ways that like they will always get away with. Like a fraternity didn't like make somebody drink so much they like had to go to the hospital, but maybe they almost got there. And it's very similar like that. Like you know, if you're not raising the red flags, you're kind of under the radar, and some of that stuff is still really under the radar. And like you know, people will report the bad people, and they still stick around, and that's sort of it's a bad culture in some places, and I think a lot of work environments probably have bosses like that too, right? Like just how that boss is, I don't know, but like that's just horrible justification for something that could be taught in a like leadership coaching and like
Right.
you could get rid of it as like a this is a never thing that we do.
Right.
I think
Exactly.
there's a mentality that if I survived it, I went through it, that you have to go through it. And until that mentality is broken, until people say, no, they don't have to suffer just because we did. It's going to take that to be a part of it because that's going to break it. And then the next generation, it's going to take them saying, you know what, I value more my family life. I value more having a mental health because, like you said, this all goes into your mental health as well. Your physical health is, if your mental health is not strong, your physical health is not going to be strong. And especially in the field of medicine, I don't want a resident who hasn't slept in 48 hours checking me out in the emergency room. Like, who
Yep.
wants that? They can't
Yep.
even, they don't even remember their own name, let alone be cognitively aware to say, oh, I think you're having a stroke, or, you know what I mean? Like, it's going to come to that point where hopefully the next generation understands that you don't have to work to death. Do you think a step in the right direction would be for residents, first year doctors to kind, or even ones that have been practicing for 15 years, to be required to see a therapist every couple months or once? Would you think that would be a step in the right direction to get them to maybe understand that humanity needs to exist as a part of medicine?
I appreciate you asking that question. There are some places that do something called opt out, which is like when there's a new class of students or when there's a new class of residents, you are automatically given check in appointments with a therapist or a coach, like however they want to define it, like somebody in a wellness role. It might be actual therapy, it might be just to check in. And if it's something, then they'll flag the right people, whatever it is, however they frame it. And it's your job to cancel the appointment. Like it's opt like you can opt out of it, but they put you into it. And so you can get out of it. In the data on that, people are much less like they stick with it longer. There's more like use to, and there's less stigma. So there's definitely a place for that. And I think it makes a lot of sense. I think it's hard sometimes just sheer volume because you have to think about where all those people are going. If they all chose to go all the time, like that's going to then make it like a pretty significant strain on the system, and you have to kind of think about what it is. I think in that sense also being mindful that like our hours are terrible, and so like you need after hours, you need weekends, like all of that is true. So you do need a specific kind of person to do some of that. Like some people love working weekends and they don't work during the week, but you have to find those people to be on the list who's doing it. I think it's harder when you get to faculty and staff because there's not like a clear orientation time, right? Like there's not like a clear everyone comes in at once and they all get appointments. Like they'd have to do it when you started the job or something, and it's just less defined. um Anybody who's listening could probably argue that like faculty and staff are often neglected in the conversation, and we spend a ton of time on students and then residents because they are underpaid and you want to help their well-being, but it's also part of like requirements to keep your accreditation and all this stuff. But faculty and staff aren't, and so they're vocally not okay, but they tend to just be given HR benefits. And I think that sometimes those are enough and sometimes they're not. And I think that's worth a conversation as we look to what we change too, because if people think that the only people that matter are the students, then it also creates more of that tension we were talking about. If it's a universally applied thing that we need to be thinking about and working on, then you feel less like you're pit against the person who's allowed to be well when you're not. And I think that matters. But yeah, I mean, I think I often say to people, like, of course, there are huge system changes that would be lovely to make, but most of the things that would make our workplace better are really boring and simple, like being more transparent, being a little bit more vulnerable, and like supporting each other a bit. Meaning and purpose are across the board preventative against things like burnout. Like, what do you like about your day? What don't you like about your day? Do you have any ability to decide that? If you don't, do you have ability to make sure that you're taking care of yourself after all the things you don't like?